Okay, so good afternoon, everyone. Happy Friday. I hope everyone's doing well today. Thank you so much for taking time out to join our echo session today. Before we get started, can I please have everyone take a minute to set their Zoom name as their first and last name, as this helps me with identifying who is on. Thank you. Next slide, please.
Ooh. Sorry.
If this is not your first echo session with us, then this will look familiar. This is the structure of all of our echo sessions, starting with announcements and introductions, followed by a didactic session in which today's topic will be focusing on the Beers criteria, high-risk medications. We will then be moving on into our collaborative case discussion, followed by closing and reminders. Next slide, please. So to make sure the sessions run smoothly, please remember to mute yourself when you're not speaking to prevent background noise. Please always introduce yourself with your name and location prior to speaking. Please maintain confidentiality when speaking about your clients by refraining from including any identifying information. And please respect others and their opinions. Next slide, please. So we are CME accredited. Our main objective is to empower providers to feel capable and comfortable with the assessment and care planning for dementia and to expand access to geriatric specialty care throughout California and beyond. So today's session is accredited for one CME credit. Certificates will be sent out by our CME office at the end of each month and will outline the total number of hours you attended. And many other licensing boards like the California Board of Nursing also recognizes CME for reciprocity. Next slide, please. So our series is a part of the HCBS Dementia Care Aware Award, which is supported by the California Department of Healthcare Services. So one of the main goals for our grant is to create a dementia-friendly California for the population in need of equitable and excellent care, the older adults, and to train geriatric specialists and primary care providers and health profession trainees to help expand our geriatrics workforce. Next slide, please. So we would like to have everyone take the time to quickly introduce themselves on videos, but since we have quite a few individuals on the line, we'll go ahead and have everyone introduce yourselves via the chat function if you can. So in doing so, please list your name, role, site, and location. Next slide, please. So in the meantime, we will go ahead and have our hub team introduce themselves on video so you can get to know us. I'll get us started. My name is Manal Khan, and I'm the project manager for Dementia Care Aware project at UC Irvine Health, and we are located in Orange, California. So Dr. Sehgal.
Hi, everybody. Welcome. I'm Sonia Sehgal. I'm a clinical professor in the Department of Medicine here at UCI, and I work within the Division of Geriatrics and Gerontology here. My practice site is in Orange, California at the UCI Senior Health Center. Welcome, everybody.
Thank you, Dr. Sehgal. Next slide, please. So today's presenter is Dr. Gurvich. Dr. Gurvich has presented before, and we're glad to have her back. So Dr. Gurvich, the floor is yours.
I'm sorry. Go ahead and start. Mm-hmm. Perfect. Okay. Hi, everybody. Welcome back. Thank you for having me again. We're going to talk today about the updated Beers criteria. We just got updated in late 2022. I think it's still in draft phase, but we'll talk about all the updates and what it is. So I'm sure you've probably seen this framework before, the age-friendly health systems. Every academic institution and every healthcare system is trying to achieve it. It's meant to provide very patient-centered care, taking into 4 important components, which is mobility, mentation, medications, and what matters most. And today's focus is on medications. So one way to sort of address that pillar in an older adult is to look at criteria that look at potentially inappropriate prescribing, understand what that criteria is, and utilize it in clinical practice. So let me tell you a little bit if you're not familiar with the Beers list, let me tell you a little bit about it. It originated in the late 1980s, early 1990s, and it was really developed. It was developed by Dr. Mark Beers out of UCLA, and the reason it was developed is because at the time, nursing homes patients were severely over-medicated. There was a giant national uproar about medications being used as chemical restraints in that healthcare setting. There were hidden cameras showing nursing home residents slumped over in wheelchairs, passed out in beds from over medication. And so that's the genesis of the Beers list back in the 1980s. But since then, they've decided that it really can be applied to any healthcare setting. So it's still very much applied in the nursing homes, but also can be used in ambulatory care settings as well as in hospitals. Dr. Beers passed away a while ago, but the American Geriatric Society took it over and has been updating it every 3 years, with the last full update being in 2019. And this one that's coming up in 2022, I think it's still in draft phase. So what the Beers criteria is a list of medications that are potentially inappropriate when used in older adults. And so it talks about why they may be inappropriate, why something should be avoided. It gives you the rationale behind it. And it allows you to make the decision whether or not to prescribe it. Obviously, they recognize the complexity of prescribing decisions. And so there's always a risk versus benefit scenario that you go through before you give anything to a patient. So just be aware of some of these medications on this list and why the reasons they're there. So if you went to my previous lecture, this is going to be a repeat, but this is one of the tables in the Beers list. This is probably as strong a recommendation from the Beers criteria board as there is. And these are drugs to avoid. And the reason you want to avoid them is because all of these are anticholinergic medications, and older adults can have issues like obviously constipation, urinary retention, tachycardia, dry mouth from these meds. But older adults in particular can also have cognitive impairment, and these meds also increase fall risk. So cognitive impairment and fall risk is really why you should avoid these medicines. And there's also this concept of the anticholinergic load, so that if one medication on this list is being used, that's bad, but more than one adds to that adverse effect. And so you want to limit the number of anticholinergics your patients are taking. Looking at this closely, so some of these are old tricyclic antidepressants. We don't use them much anymore, but remember, even at low doses, even like amitriptyline 10 milligrams or 25 milligrams or nortriptyline 10 milligrams can have some anticholinergic activity, which could cause patients to have cognitive slippage. Paroxetine is on this list. It's an SSRI with a very slight amount of anticholinergic activity. So you probably don't want to use it in someone who's got cognitive impairment at baseline. With these antiemetics, we still use a lot of promethazine. That's Phenergan. We use it a lot, obviously, during COVID. So remember, that's an anticholinergic that can potentially cause problems. The antihistamine section, most of these are OTC. So you really do want to ask patients what they're taking over the counter. Sometimes you're very surprised by different combinations of products they use that have these sedating first generation antihistamines in them. Meclizine is on the list. We use that a lot for dizziness, but it can cause cognitive impairment, so it's considered a high risk drug. And hydroxyzine is the antihistamine that's still prescription, so that one you have a little bit of control over. The urinary antispasmodics, they're all anticholinergic, all can potentially cause cognitive impairment. Oxybutynin is probably the worst one. Trospium is probably the better tolerated one, but still should avoid in patients with dementia. Anti-Parkinson's agents that are listed aren't used very much anymore. Antipsychotics. Olanzapine is an atypical antipsychotic, which is low in EPS, but still has significant anticholinergic activity. Some of these antispasmodics at the bottom, a lot of them are GI antispasmodics used in patients with IBS with a predominant symptom of diarrhea. Atropine, obviously we're going to use it if it's in a crash cart, it's an emergency, but atropine is also available in Lomotil. That's one of the ingredients in Lomotil for diarrhea. So that one needs to be used more cautiously. Some muscle relaxants, especially cyclobenzaprine, for example, that's actually tricyclic in its structure and also has anticholinergic properties, and scopolamine patches, for example, would not be appropriate to use in older adults. So then there is this table of representative drugs which are potentially inappropriate. So it's not that you shouldn't use them at all, it's that you should be cautious about using them and use them in particular situations, and keep in mind the reasoning behind them being on the Beers criteria. So for example, nitrofurantoin, it's an old established antibiotic, but with creatinine clearance of less than 30, there's a risk of lack of efficacy and increased risk for pulmonary toxicity if it's used chronically. So probably don't want to use it in your patients with significantly reduced renal function. Things like muscle relaxants, benzodiazepines, the Z drugs, they can all cause sedation, cognitive impairment, fall risk, and fractures. And we talked about that at the last lecture. So you do want to avoid those. There's a benzodiazepine 2022 update, which will be in the following slide. The antipsychotics should be used very cautiously in older adults, especially in those with dementia and behavioral disturbances. You really want to explore other options for managing those behaviors. Really focus on identifying them specifically and making sure that, first of all, that these drugs are effective for them, but also that this behavior is actually endangering the patient, preventing their care, or harming the caregiver. Otherwise, they're really not appropriate because they do increase the risk of stroke and mortality. And there's an update for that, and I'll share that in the next couple of slides. Proton pump inhibitors are on this list with a 2022 update, and they really do focus on why you don't want to be on long-term PPI therapy. So it's okay to be on them for less than 8 weeks, but you should avoid them for more than that because they do increase the risk of C. diff infections, which are commonly seen in older adults. They do increase the risk for pneumonias, GI malignancies, vitamin deficiency, like a B12 deficiency, for example. So if you do have somebody on long-term PPI therapy, you should monitor B12 levels, which is also important with cognitive decline. There's an increased calcium absorption problems, so decrease in calcium absorption and bone loss, and fractures that result from that. So you don't want to give PPIs like water. Sometimes I look at our patients and we're just routinely refilling them. Probably not a good idea. All NSAIDs are on the Beers criteria. So they're all on there for increased risk of bleeding, obviously increased risk of peptic ulcer disease, and increased risk for renal insufficiency. There are a couple that are specifically called out for their toxicities, and that's things like Toradol and indomethacin. There's a special section for those two NSAIDs to make you aware of the increased risk of more toxicity, but all NSAIDs are on the list, even the COX-2 inhibitors. You don't want to use sliding scale insulin without basal insulin. The risk of hypoglycemia is great, and there's really no significant improvement in hyperglycemia with that kind of management. So you really do want to simplify insulin regimens as much as possible. There's a 2022 update for sulfonylureas. Prior to 2022, only the longer acting sulfonylureas were on the Beers list for their risk of hypoglycemia. So gliperide's been on it for a number of years, and glimepiride. Now they're adding glipizide as well, because they all increase the risk of hypoglycemia and really should be avoided in older patients. SGLT2 inhibitors made it on the list this time around. They should be used with caution because of side effect profile, really, that older adults are at risk for. So increased risk for urogenital infections, UTIs, and fungal infections that older adults will have at higher frequencies, and also ketoacidosis. Magestrol really should not be used for weight gain. It's got minimal efficacy and an increased risk for thrombosis. Centrally acting alpha agonists like clonidine, for example, it works very well for lowering blood pressure, but not without risk. It's a centrally acting agent with the risk of excessive sedation, grogginess, sometimes confusion. So really, you should only be used as a last resort when you can't manage blood pressure without it. And alpha blockers like doxazocin or terazosin really do increase the risk of orthostatic hypotension. So their use should be limited as well. Testosterone should be used very carefully in the older adults, only if there's confirmed diagnosis of hypogonadism. Otherwise, there are lots of reasons not to use it. Prostate cancer, cardiac issues, cholesterol issues. So you want to stay away from that generally. Desmopressin made it on the list in 2022. That's an update. There's an increased risk for hyponatremia, and there are safer alternatives available. Desiccated thyroid, not an ideal thyroid supplement to use in older adults, very unpredictable levels. It's much safer and easier to use levothyroxine. And then metoclopramide is a dopamine antagonist, which causes extrapyramidal side effects, and you want to avoid long-term use. This is the 22 update for benzos. Again, if you went to the last lecture, you heard this already, but basically older adults don't tolerate benzos well. There's an increased sensitivity to side effects, increased risk for grogginess, sedation, confusion. Certainly shouldn't be used in cognitive impairment if you're trying to prevent reversible causes. And you want to be very careful using benzos in combination with opioids, and really that you should be avoided because the risk of overdose is significant. Here's an update on antipsychotics. Again, this is a repeat from the previous lecture. They want you to remember the FDA-approved indications for the use of antipsychotics, which do not include agitation associated with dementia. You really should avoid using them in these behavioral problems. You want to try all behavioral interventions at your disposal to see if that would be effective enough to get rid of or reduce the behavior. You want to document that trial. You want to use these drugs as a last resort in patients, and in collaborate, you really want to talk to the families, caregivers, and patients if they're able to understand about the risk versus benefit kind of analysis that goes into prescribing these. There should be periodic assessment of efficacy, because a lot of times these aggressive behaviors aren't responding to the antipsychotics, and we still prescribe them. So we need to step back and figure out, is this behavior going away as a result of adding an antipsychotic or not? And we do want to periodically deprescribe and lower the dose of these agents so that you're using the lowest effective dose used. Warfarin made it onto the 22 update. It's no longer the drug of choice for initial therapy for thromboembolic disease or non-valvular AFib. The newer DOACs are preferred. So you can use warfarin if there's an issue with either getting DOACs approved through insurance, or cost is prohibitive, or for some reason DOACs are contraindicated. However, in stable patients who have stable INRs, who follow up with Coumadin clinic, whose medications don't change from month to month, causing drug-drug interactions, it's okay to continue Coumadin. But there is a higher risk of bleeding and lower efficacy for thromboembolic disease and non-valvular AFib. Here's another type of table that's in the Beers list. This is potentially inappropriate medications when used in certain diseases or syndromes. So if your patients have a fall history or syncopal episodes, you want to avoid these agents if possible. Now, this presents an obvious problem. If you look at this list, some of these drugs are used very frequently. Okay, so you don't want to use antipsychotics because there are issues with it. You don't want to use benzos or the Z drugs, but you do want to use SSRIs, SNRIs, mirtazapine, sometimes gabapentin. How do you go about doing that if there's a fall history or syncopal episodes? Well, this is where it comes down to dosing and close monitoring. So you want to start with a very low dose. So for an SSRI, for example, if you're starting Lexapro, you don't want to go higher than 5. Celexa, no higher than 10. and titrate up gradually, monitoring for dizziness and falls. You don't want to have cocktails of antidepressants if you can avoid them. So, if somebody is in pain and needs duloxetine and depression and they need an SSRI, maybe you don't need the SSRI and you just use duloxetine for both indications. So limiting the number of meds that can increase falls is generally a good idea. Cholinesterase inhibitors, if somebody's demented, that's sort of the first drug of choice, right? Well, that's why you want to start a lower dose. Like if you're using Aricept, you want to start with 5 and wait a good month to even maybe sometimes 8 weeks to see how the patient tolerates it. If they're dizzy, if they fall, then maybe cholinesterase inhibitors are not the appropriate agent. And if they're on 10 milligrams of donepezil, for example, you would lower it to 5 to see if that improves. Things like tricyclics, you don't want to use for other reasons as well. So that's not an issue really. Alpha blockers, again, they cause a lot of orthostatic hypotension. So their dose should be, their use should be limited. If somebody's got delirium or cognitive impairment, you want to avoid all the anticholinergic drugs. So tricyclics, other anticholinergics, sedative hypnotics, antipsychotics with anticholinergic activity, steroids long-term, and H2 blockers. Here's the thing with H2 blockers. You don't want to use them in active delirium, but you can use them in chronic dementia where a patient is not in delirium, because you don't want to use a PPI long-term. They really don't want to use them. So instead, you should use H2 blockers in stable patients. In heart failure, NSAIDs, COX-2 inhibitors, verapamil, diltiazem, and things like Actos have always been on the Beers list with this indication. The 22 update is that they've added dronedarone to the list. You don't want to use it because it can potentially cause adverse reactions and increase mortality. For urinary incontinence, there's an update in 2022. So generally, this is old. You don't want to use oral estrogen or transdermal estrogen because there's an increased risk for cancer, increased risk for thrombosis, and lack of cardiovascular benefit. But the 22 update deals with vaginal estrogen. So you can use it if a patient has recurrent UTIs, and you can use it for atrophic vaginitis, provided there's a shared decision making process with the patient, discussing the risks associated with estrogen use and the benefit they might get if they have atrophic vaginitis or recurrent UTIs. Remember, vaginal absorption of estrogen is decent, so you can have systemic effects. So there is a risk of thrombosis there as well. Then there is a table of drugs that should be used with caution. There is an update for aspirin. Aspirin is no longer indicated for primary prevention in anybody over the age of 60 because the bleed risk outweighs the benefit. So you don't need, a lot of people don't need to be on aspirin anymore. They're updating the recommendations for DOACs. So Pradaxa definitely causes more GI bleeding than Coumadin, and you really don't want to use it in patients over 75 because of the increased bleed risk. Rivaroxaban, it's a once-a-day drug. So sometimes if compliance is an issue and they can't do Eliquis twice a day, Rivaroxaban becomes a more attractive option. But it does have to be renally adjusted, and there is an increased risk of bleeding compared to apixaban. With SSRIs and SNRIs, mirtazapine, tramadol, and antipsychotics, there is a risk of hyponatremia. Usually I see it when these drugs are given at higher doses or in a cocktail of multiple medications. So again, most of the time this hyponatremia is relatively mild. So you just kind of keep an eye on the sodium and move forward. If it drops, say, below 130, you probably do need to address it, maybe by lowering the dose or getting rid of some of the cocktail drugs in the same cocktail. So, I see it a lot when somebody's on a Zoloft, for example, and a tramadol for pain, and a trazodone for sleep. So 3 different meds that can contribute to this hyponatremia. So get rid of those cocktails if you can. And then for Nuedexta, the dextromethorphan quinidine combination, you really don't want to use it for anything other than pseudobulbar affect. That was a 2019 recommendation. The 2022 update is that there's also a risk of QT prolongation and increased risk for falls. So avoid that drug if you can. And then there have been a bunch of, there's a deletions section on the Beers criteria. And for the most part, these drugs are just old and not used very much anymore. So some first generation antihistamines, which we're not using, some antispasmodics that are rarely used. If you look at some of these other things like barbiturates, hydrogene, I mean, I've been in practice for a while. I remember hydrogene 25 years ago, but I haven't seen it since. Some of these cardiovascular medications are also really old and unused, old NSAIDs and chlorpropamide, which I haven't seen used in over 30 years. There's also a drug-drug interactions in the Beers list, and these interactions aren't necessarily new. They're just common in older patients. So for example, with an ACE or an ARB and potassium-sparing diuretics, there's an increased risk for hyperkalemia. Well, you can monitor that and be fine on this combination, but when you add Bactrim, that's when you can really see serious hyperkalemia short-term. So before you prescribe it, keep an eye on the potassium and see where it's at. They want to avoid cocktails of meds again. So these CNS active cocktails with opioids, antidepressants, antipsychotics, benzos, the Z drugs, skeletal muscle relaxants have been added to this list. You want to avoid combinations of 3 or more. So you really want to limit your cocktails in older adults. Sometimes that's an issue because, we want to limit narcotic use. And so we're trying to add things like gabapentin and maybe duloxetine. And now you've got a combination of 3. So obviously it's always a clinical decision, kind of a judgment that you have to make, keeping doses as low as possible with very careful monitoring. Again, this concept of anticholinergic load comes up. You don't want to use multiple anticholinergics because it does decrease cognitive function. With peripheral alpha blockers and loops, there's an increased risk for urinary incontinence in women. We generally don't see peripheral alpha blockers used in women very often, so it doesn't come up too frequently. With Coumadin, it used to be on a 2019 table, but they're removing it, not because it's the interactions aren't there, they are, but because they're not limited to older adults. These interactions with Coumadin happen in all age groups, so it's not relevant just to older patients. And they're also removing older drugs like theophylline, which interacts with a lot of things, and dilantin, because they're just not used anymore. Here's a renal dosing table. So a lot of antibiotics that are on this list. Some antidepressants like duloxetine has to be renally adjusted or shouldn't be used below the creatinine clearance of 30. Tramadol, more side effects associated with use with reduced clearance. Then you've got gabapentin, pregabalin that we use a lot in seizure meds. There is generous renal adjustment dosing for those 2, but it does have to be adjusted with creatinine clearance less than 60. H2 blockers, you have to do a little dose adjusting as creatinine clearance falls below 50. So that's something to keep in mind. And they're updating the rivaroxaban, apixaban, and dagabatran on this 2022 update. So apixaban is now the drug of choice in CKD and end-stage renal disease. So it's going to be removed from this table. With rivaroxaban, they're going to follow manufacturer dosing guidelines for renal insufficiency, and dagabatran is poorly tolerated in older adults, so really shouldn't be used. When you look at these cutoffs, they're pretty standard. If somebody's creatinine clearance is 60 or 50 to 60 or higher, you generally don't have to do many adjustments. 50 to 30 is kind of clinical judgment. And less than 30, you probably want to avoid because there are lots of side effects associated with use of some of these drugs with reduced renal function. Ciprofloxacin has lots of reasons not to use it with poor renal function. Some Bactrim, spironolactone, and triamterene, you're really at risk for hyperkalemia there. So what I want to do now is go over a patient case, which kind of illustrates some of these points that we just talked about. So this is a patient who presents for consultation for medication review with very specific concerns about this patient's inability to manage blood sugar. So 86-year-old gentleman with a history of type 2 diabetes for 15 years, hypertension, hyperlipidemia, coronary artery disease, status post-PCI. Other issues are BPH, insomnia, low mood, and mild dementia. And the patient has recently started complaining of incontinence and sudden onset of allergies. So just looking at this problem list, I'm thinking, and this med list over here, some of these new onset medical problems could be medication related. So let's take a look. His MoCA is a 20, so he's sort of still in the mild cognitive impairment phase, but moving closer to mild dementia. Family checks blood sugar 2 to 3 times a day. Average blood sugars are fasting in the 150s, postprandial 2 to 300s. So elevated, but not terribly concerning given his significant comorbidities. Family is trying to manage diet tightly to the dissatisfaction of the patient. Family feels he doesn't understand the importance of glucose control anymore due to his cognitive impairment. Patient used to be a marathon runner and always kept his health as a top priority, and that has slipped over the years. Prior to dementia diagnosis, the A1C values were in the 6 to 6.5 range. So looking at his med list, he's on metformin max dose. So we definitely want to look at kidney function there. Amaryl 8 milligrams. So on the Beers criteria for increased risk for hypoglycemia. Januvia 100, not first, second, or third line anymore for diabetes and at max dose. So you do want to look at kidney function. Metoprolol 50 once a day. So obviously blood pressure and pulse needs to be looked at. Flomax. Sometimes Flomax can cause dizziness during the day. So sometimes it's better to give it at night. But then there's the issue of frequent urination. So you have to kind of balance that out. Lipitor 40, aspirin 81. Donepezil 10 milligrams. So donepezil is a cholinergic agent, which can cause things like diarrhea, frequency in urination, bradycardia. Those are some of the common side effects. Drooling, watery eyes, things like that. So this recent onset of incontinence and allergies could be a little, side effects from the donepezil use. He's on diphenhydramine 25 to 50 milligrams at bedtime. So this could be helping with the allergies because it dries you out, but it's diphenhydramine, first generation antihistamine, which can significantly contribute to his cognitive decline, should not be taking that medication. He's got Lomotil for loose stool. Again, that could be a donepezil side effect and a metformin side effect as well. And because Lomotil has atropine in it, it's on the anticholinergic list of not to use. So there's your anticholinergic load increasing. So, and then trospium for incontinence, also anticholinergic and relatively well tolerated compared to some of the other overactive bladder drugs. But given his diagnosis of dementia, this is not a good idea. So he's on 3 anticholinergics that really should not be there given his dementia diagnosis. So what we would do at the Senior Health Center, if we were evaluating this gentleman, we would probably take him off the anticholinergic meds, maybe adjust his donepezil dose a little bit, maybe to 5 milligrams, and then retest him to see how severe his dementia is. Looking at his labs and vitals, his heart rate's 52, so low end normal, probably obviously due to the beta blocker, but also to the donepezil as well. So I gave you height and weight so that you can calculate estimated creatinine clearance, which we still do in the office. His serum creatinine is 1.6, which is slightly elevated. I did the calculation for you, and I've got the formulas on the next slide if you want to use them in your office. Estimated creatinine clearance using ideal body weight is 31 mils per minute, so that's fairly low. So metformin is pretty close to being having to be dose adjusted there. Januvia, he should not be on more than 50 milligrams daily. So with reduced function like that, you might consider changing to Tradjenta if you wanted to do a DPP-4 inhibitor. But how do you deal with the family wanting those blood sugars to be in better control? I think education comes into play there. We need to let them know that there's no need to be at an A1C of 6 to 6.5 any longer. This patient has multiple comorbidities, multiple medications that can make them dizzy, can increase the risk of falling. So really, no need to be that aggressive with his diabetes. And 8.5 is pretty close to his goal, really. Something in the low 8s would be appropriate. So if we had to back off the metformin and maybe back off the glipizide and Januvia, maybe we start an GLP agonist if we want to control the A1C a little bit more aggressively, because it doesn't have to be renally adjusted, and that could be a once weekly injection that takes care of the problem. So let me show you on the next slide. These are the formulas we still use. So this is the formula you would use to calculate estimated creatinine clearance. So age is a factor here, so that's why we use this formula. And you multiply the whole thing by 85% for females. And these are the general cutoffs. Creatinine clearance greater than 50. You can use just about any drug at any dose. 30 to 50, that becomes clinical judgment, and sometimes you have to do some dosing adjustments. And creatinine clearance less than 30, that's when some drugs are not indicated to be used. And here's the ideal body weight and adjusted body weight formulas that we sometimes use. I like ideal body weight because creatinine is a byproduct of muscle mass. And so if you use total body weight, most of that weight is due to fat. It's going to overestimate your creatinine clearance. Sometimes in your very obese patients, even adjusted body weight is not good enough. So when I figure out ideal body weight, I'm getting the most conservative estimate of kidney function. And then you can loosen it up from there a little bit. But it's a pretty straightforward formula for men and for women. So I think the important thing here is to kind of simplify the medication list, reset family expectations for their diabetes, try to get rid of some of the anticholinergic drugs that are on the list, and maybe retest the patient to see if his cognition improves. And remember that even the dementia meds have side effects, especially the cholinesterase inhibitors. Frequency in urination, incontinence, bradycardia, runny nose, drooling are very commonly seen in older adults on these medications. So sometimes dosage adjustment is necessary. Any questions?
Thank you, Dr. Gurbich. So we actually do have one question in the chat. Someone would like to know how to identify elderly patients that would really benefit from a pharmacy consult, or is it everyone?
So the trick with the sort of the standard for polypharmacy is anytime you have a list of 5 or more meds, you should go over them. Maybe Dr. Sagel could speak to this, but I feel like anytime I see a med list, I feel like I can do something with it. So I would say, I think all older adults should have access to a clinical geriatric pharmacist so that we could tighten things up. Because sometimes it's just little tweaks, reducing the dose a little bit or changing one medication for a slightly different one. So I think everyone should do it, but I don't know, maybe Dr. Sagel can answer that more practically.
Yeah, thank you, Dr. Gurbich. So thank you very much for that wonderful presentation as well. I agree. I think if you have a geriatric pharmacist available in your practice, that's the way to go. And I wish every practice had such an individual. But I think Dr. Gurbich is right. So when you see more than 5 medications, or you start to see new symptoms that develop shortly after starting a medication, it's time to review And if you don't have a geriatric pharmacist available, sometimes we'll schedule an appointment just to review medications. And it can be a video visit, like a telehealth visit, or an in-person visit, and we'll just spend the entire time going over medications one by one. But certainly if you have a geriatric pharmacist who can do that for you, that's really the best.
Thank you. We have another question in the chat. So how soon after medication change would you repeat MOCA?
So I would wait at least a few months before I did that. I think it takes time for the medications to kind of clear and reset. So I think we usually retest in 3 months, 3 to 6 months. Is that what we do?
I agree. Mm-hmm.
Thank you. Please feel free to unmute yourself or put any questions in the chat.
Thank you, Dr. Gorbach. Great presentation. When you discontinue some of these medication that can affect the memory, what do you tell the family of how much of an improvement in the patient memory should they expect after discontinuing these medicines?
So I think it depends on the severity of the symptoms that they present with. If it's something like MCI, I would expect, like if this gentleman had MCI and we got rid of 3 anticholinergics, honestly, in 3 to 6 months, you might see a pretty significant reversal of the issue. If they've got more severe dementia, I think you might see some improvement, but I don't know that you'll see it go back to being whatever normal is.
Thank you.
Any other questions? Again, feel free to unmute yourself or put any questions in the chat.
I have another question. So if the insurance doesn't approve certain medication, have you had any success telling the insurance company your recommendations are based on this Bears criteria?
Yes, absolutely. So this month has been horrendous in clinic. None of the medications our patients are on seem to be covered because insurance plans change every January. And so this is an awful month for this. I'm sure, Dr. Rahimi, you're seeing the same thing. So yes. We end up doing a lot of PAs. I think the justification you put into the PA really determines whether or not something gets approved. And, you can say, according to the updated Beers list, this is no longer the recommended drug, and the harm outweighs the benefit for my patient. And they, I think you have a better chance of getting this covered. I think the other important thing you have to tell patients is that every year during open enrollment, they have to look at their Medicare Part D plan and look to see what's going to be covered next year on it and what's not. And that's when they can, like in our office, they can come in and see us, and we can run the Medicare Part D finder with them and find the plan that will cover some of the medications they're using. So that's really key to avoid insurance problems, because every January plans change, and it seems like fewer and fewer things are being covered.
That's a great idea. Thank you.
So we have another question in the chat, and I apologize if I totally butcher this, but it is, can mirabegron be a choice for UI in these patients?
So yes, mirabegron, so Myrbetriq is a much better option for incontinence in older adults. So it's a beta-3 agonist. It does not have any anticholinergic activity. The only issue with mirabegron is an increase in blood pressure. So you do have to keep an eye on that. There's a new drug that came out a few years ago. I think the generic is, it starts with a V, but it's another Gron. It's Gemtesa is a brand name, and that doesn't have the blood pressure elevation issue. So it's a beta-3 agonist, just like Myrbetriq, but doesn't have the blood pressure elevation, and certainly no anticholinergic activities. And this year, I don't know how well it's covered by insurance, but I think in the next couple of years, I think that'll start changing probably as prices go down. But yeah, Myrbetriq is a much better alternative than any of the anticholinergics, even with a risk of hypertension.
Thank you. So any other questions? So we have another question. So what's your opinion about high dose statin for a patient with mild dementia at 86 years old?
So my opinion is this. There are no guidelines for patients over 80 for statin use. So you really have to kind of look at individual patients. We have a lot of patients complaining of muscle pain, muscle weakness with high dose statins. We've had a couple of patients who've had strokes and were put on high dose statins and then couldn't participate in rehab because they had so much muscle pain. So you have to kind of look at individual patients, and if you have to get them on a higher end dose, titrate it up slowly. You can't just slap an 80 milligram atorvastatin on an 80-plus-year-old patient and assume that they're going to tolerate it well. Dr. Sagel, do you have anything else to add?
No, I agree. I'd really look at the indication and make sure 80 milligrams of atorvastatin is really warranted.
Thank you. Any last questions?
Hi, good afternoon. This is Dr. Dasambuha. Thank you, Dr. Grivich, for your great presentation. I have a quick question. For aspirin use in secondary prevention, what are your thoughts on starting aspirin?
So I think for secondary prevention, it's okay. I think you would want to use a baby aspirin as opposed to a higher dose aspirin. But there haven't been any restrictions for secondary prevention as far as I know.
Thank you.
Thank you. Any last questions? Okay, well, thank you, Dr. Grivich, for your great presentation, and thank you everyone for your questions. So if we can go to the next slide. So if you wish to receive CMEs, please fill out the form at the following link, or you can scan the QR codes. I've also put the links in the chat. We also ask that you complete the evaluation form, as this helps us with our continuous quality improvement efforts. This presentation and links will be sent in a follow-up email before the end of the day, and I will also be sending out a link to last week's recording. So both of these forms will close at 11:59 p.m. on Tuesday, so please be sure to submit these as soon as you can. And also please join us next Friday, February 10th, for our 9th ECHO session, which will be on the topic